Okay. Hello, everyone, and thank you for joining us today for our 2025 Research Updates from ASCO webinar with Dr. Smitha Krishnamurthi and research advocate Annie Delores. My name is Carly King, and I'm the Research Advocacy Specialist here at Fight Colorectal Cancer. Fight Colorectal Cancer is the leading patient empowerment and advocacy organization in the U.S. We provide balanced and objective information on colorectal cancer research, treatment, and policy. We're relentless champions of hope, focused on funding promising, high impact research endeavors while equipping advocates to influence legislation and policy for the collective good. Before we get started, I just want to cover a few housekeeping items. First, a quick disclaimer. The information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you're ill or suspect that you are ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. Next, we'll have dedicated time at the end of the webinar for a Q&A session with our presenter. Please feel free to use the Q&A panel on the right side of the screen to ask any questions that come up along the way, and we'll do our absolute best to address them at the end of the webinar. Lastly, we'll have a recording of this webinar on our website available within the next few days. You'll receive a direct link via email as soon as it's available if you're registered for the webinar. So with all that, I would like to briefly introduce our presenters today. Joining us today is medical oncologist Dr. Smitha Krishnamurthi from the Department of Hematology and Oncology at the Cleveland Clinic and research advocate Annie Delores. Thank you so much, both of you, for taking the time out of your day to join us today, and as well as all our attendees. And I'm going to hand it off to Dr. Krishnamurthi so we can get the webinar started.
Okay. Thank you so much, Dr. King. Let's see. Can you see my slides?
Yes.
All right. Such a delight to be here, and I'm so grateful for the invitation and the chance to discuss with Annie and all of you. So we've got so many good abstracts this year from ASCO. Just like a little overview for patients with deficient mismatch repair, colon cancer, or high microcell instability, MSI-high. There's the ATOMIC study of adjuvant immunotherapy, and we'll look at CheckMate 8HW for treatment of metastatic disease with immunotherapy. And then for patients with proficient mismatch repair or microsatellite stable colorectal cancer, there's the Breakwater study for patients with BRAF V600E mutant colorectal cancer. And we're going to look at some exciting new studies of immunotherapy in this population. And lastly, we'll end with challenge, a trial of exercise as an adjuvant therapy for colon cancer. So please shoot us your questions along the way. So to start with, this was ATOMIC, which was presented at the plenary session, such an important study. This is a randomized trial of chemotherapy alone or with atezolizumab, which is anti-PD-L1 antibody immunotherapy is adjuvant therapy for patients with stage 3 deficient mismatch repair colon cancer. And these were the key takeaway points. FOLFOX, CAPOX, that's been our standard adjuvant therapy for all stage 3 cancers, basically since about 2004. And this study found that adding atezolizumab to FOLFOX6 significantly improves disease-free survival for patients with deficient mismatch repair stage 3 colon cancers. And so this is now a new standard adjuvant treatment. This was the study design. It was good to see they enrolled patients even, they allowed patients to enroll even as young as age 12 because many of these patients might have Lynch syndrome, could be quite young. And they had to have a performance status of a 2 or higher or better, and randomized to the standard FOLFOX6 for 6 months versus FOLFOX6 plus atezolizumab for 6 months, and then an additional 6 months of the atezolizumab alone. And the primary endpoint was disease-free survival, which has been found to correlate well with So this was the data, the 3-year disease-free survival, 86.4% with the immunotherapy added to chemo, compared to 76.6% with the chemotherapy alone. And of course, there were immune toxicities with the addition of the atezolizumab. In terms of grade 3, 4, it's diarrhea was most common, about 12%. Most of the toxicities were, low grade, but there is a risk, of course, of hypothyroidism that was 20%, and that could lead to long-term thyroid replacement tablets. And they were just highlighting here some grade 3, 4 toxicities, hepatitis, 5%, pneumonitis, 2%. And I included this was the lay summary they had provided, which I think states this very well, that adding this immunotherapy to chemotherapy reduced the risk of recurrence and death by 50% compared to chemotherapy alone in these patients with node-positive colon cancer. The side effects were as expected. I'm sorry, I forgot to mention one that was unexpected was neutropenia, which we were not expecting with atezolizumab, but that was increased with that arm. And this certainly establishes atezolizumab and FOLFOX as a new standard treatment for patients with deficient mismatch repair stage 3 colon cancer. So should I stop there? And this was the last slide for the study.
Well, I don't know. We'll wait till Carly can tell us, but this is Annie. I was just going to say this was a long time coming. This started in 2017 when the standard of care was only to give chemo, as your slides show, and to show that immunotherapy is important is great. It's what's hard is that between being designed and being fulfilled, the IDEA trial came in, and that was in ASCO 2017, where for low risk stage 3, 3 months of chemo is considered enough. So I can understand that this might have gotten really difficult to enroll early stage patients. Do you think so, Dr. Krishnamurthi?
Yeah, certainly. Uh, the 6 months might have been a deterrent. The promise of the atezolizumab probably, kept the study going. Also, what's happened, since the study was launched many years ago was the finding of the efficacy of neoadjuvant immunotherapy. For example, with the niche trial, just 2 doses of immunotherapy, and then at surgery, 2/3 of the patients having a pathologic complete response, and they showed 3-year disease-free survival of 100%. But we have to keep in mind with that study that it's especially the initial one, niche one, was like just anybody had resectable disease. So they could have had very early stage disease. We do know that even in niche 2, they were looking for patients with the bulkier tumors. But CT staging is not perfect for colon cancer. And so like in Foxtrot, we saw even when you think you're enrolling T3, T4 tumors, that 25% of them were low risk stage 2 and would not have warranted chemotherapy. So we can't really do an apples to apples comparison of the niche results with Atomic. But certainly for, now we still have, we want to give patients who have obviously locally advanced deficient mismatch repair colon cancer neoadjuvant immunotherapy. But there are, plenty of patients who still go to surgery first because their tumors don't look particularly advanced. And then we might find out after the fact they were node positive. And it used to be like so hard at tumor board because the surgeons would say like, well, can't you just give them immunotherapy? And I'm like, no, I can't. There's no data. So now we have this data and it's wonderful. Like now we can offer immunotherapy if there's no contraindication.
That's a great way to phrase it all. What was lovely, like re-listening to the presentation, is that one of the recommendations that Dr. Chalabi have, who's a discussant and who's the PI for the niche trial, is let's get everybody tested by surgeons before you do surgery, which is what's happening in rectal cancer. Is because for stage 3 rectal cancer that are MSI, they can do immunotherapy right away because of NCCN
Right.
guidelines. So I think what's really hard is that a lot of stage 2 and 3 MSI patients are really disappointed to find out that the open window was before surgery. Um,
Right.
and like there's a ZER2 trial that's out there trying
Mhm.
to serve this population to sort of organ sparing. There's also a trial at the NIH that is for MSS or MSI that you can just like apply for it, but it's a 2-year commitment, so it might be easier for people on the West Coast and just get immunotherapy, If it doesn't work, you would go to surgery. But I I can totally see that as being really relevant, especially somebody like with sigmoid colon, where it's like,
Mhm.
it might not be rectal in terms of like the extent of the surgery, but it's still a big deal what goes on with, to me. Please
Yeah, no,
disagree, doctor.
I agree. Like, if it's a low sigmoid tumor, there might still be some low anterior resection syndrome symptoms after
Yeah,
surgery. Um, and also that tumor might be easier to monitor, right? Because it's like you could reach it with a flex sig. It's this non-operative management for colon cancer gets tricky when it's like a right-sided tumor. And then how often do we subject somebody to a colonoscopy to keep an eye on that area? All this still to be seen in studies.
those are great insights. That's the kind of thing that's like where a medical oncologist is going to see like even further into like all the issues. So, and then I was just going to say that two things. One, I love these lay summaries that ASCO is insisting on, and there's actually often QRR codes for people to get
Yeah.
to be able to download slides. But then I was just going to say that this movement of immunotherapy in early stages for MSI can eventually help for moving immunotherapy into early stage for MSS. If the Tarzan trial had some results in rectal cancer, the Nest-1 trial. So people are interested in finding ways to find people who immunotherapy might work for, and it might be in the earlier stages.
Yeah, absolutely. That's a fantastic point because even like niche, it looked so much more effective than immunotherapy for patients with metastatic DMMR cancer. So there's something about that neoadjuvant environment, perhaps, that before a cancer has figured out a way to metastasize, the immune system is keeping it in check and may get a more robust response. Um, and also Nest, as you mentioned. And thanks, Annie, about the NIH trial. I have to look that up. I didn't know about that one. So
It's Dr. Clemen, and it's great that it's like they will test to find out if you're MSS, MSI. So, I mean, if I think it's harder for people who live I'm in San Francisco, so it's harder for people to commit to going to the NIH. But the
mm,
NIH, actually pays for travel and lodging, so
they do.
it is doable. And there's also way back when Dr. Galan talked about immunoscore for people over the age of 70
Mhm.
for stage 3, maybe not might not be good at all. So, there are people who are over 70 who are sort of, uh, they're not frail now, but like going through surgery might be a lot to put them through. So I think that's a population that's in need that nobody quite is rooting for them, but there's an Italian surgeon who's rooting for them.
Yeah, that's a great point.
So I'm not sure where.
I can't see the chat.
I think the chat was just me, so we don't have any
Okay,
questions at this point, so I think we can move
okay,
on to the next talk,
keep
and I'll
going.
let you know when we get
All
something.
right, so moving on to immunotherapy for patients with metastatic deficient mismatch repair colorectal cancer. This was an update of Checkmate 8HW. This trial had this is looking at nivolumab plus ipilimumab, so dual immunotherapy versus chemotherapy or nivolumab alone for patients with microsatellite high colorectal cancer. And so this was the study design. It actually had so it had these multiple arms, but it was also for multiple lines. So there was patients who were being treated in the first line could be enrolled to these arms, and including chemotherapy. And then patients who had already had first-line chemotherapy would be enrolled to the immunotherapy arms. And so originally they had presented the data showing that ipilimumab and nivolumab is quite superior to chemotherapy in terms of progression-free survival. And we were expecting this because we'd seen similar results with pembrolizumab. But everybody was waiting to see, like, well, do we need both agents? How does 2 versus 1 compare? And so that's what we're going to see. This is the dual immunotherapy, nivolumab and ipilimumab versus chemo. Really high progression-free survival rate, 74%. growing
Oh,
versus only 11% with chemotherapy. And obviously, this difference is persisting. It looks like a sustained benefit. And this was, just doing a cross-study comparison. We knew compared to like the study of pembrolizumab versus chemotherapy, there had been a 29% of patients who had a rapid progression on pembrolizumab, and that was, not as pronounced with this doublet immunotherapy. This study also did central confirmation of the mismatch repair status and found about 14% of people who were registered or actually had proficient mismatch repair. So that might have affected the results in the pembrolizumab trial. But moving on, then they looked at, here we go, Nivo-Ipi, the doublet versus nivolumab. So here in orange, the doublet is showing it's 71% PFS at 24 months versus 55% with single agent nivolumab. And this was clearly superior. The hazard ratio is like 0.62, so a 38% reduction in risk of progression or death. And then they looked at like, what about after patients progressed and then go on to the next treatment? If we look at from the time they're randomized to the time they progressed on the second treatment, does it even out? Because maybe you could give the, salvage with a second line treatment, but really this is the PFS2. So from randomization to progression on the second treatment, and it's still superior to have the nivolumab, ipilimumab first versus nivolumab. Although when you look here at the subsequent therapies, in the green, the patients who received nivolumab, single agent, only 14% got another immunotherapy. And we don't know actually that a person could be salvaged with giving ipilimumab after nivolumab, but certainly it looks like starting out with a doublet leads to uh, sustained high rates of being alive without the cancer progressing, which is terrific. Of course, doublet immunotherapy is going to be more toxic. We're expecting this treatment related adverse events grade 3, 4, 22% with ipi-nivo versus 14% with nivolumab alone. There were 2 out of 352 patients died who received ipi-nivo, one from pneumonitis, inflammation of lungs, and one was myocarditis, so inflammation of the heart. These are, of course, very scary toxicities. And one patient died from pneumonitis in the nivolumab alone arm. Oh, sorry. No, for sake of time, I'd remove the immune related adverse events slide. But what we expect with a doublet is more endocrinopathy. So there is more hypothyroidism and adrenal insufficiency with the doublet, and rash that's particularly pronounced. So in summary, first-line nivolumab, ipilimumab continues to demonstrate improved progression-free survival versus chemotherapy, but also demonstrated superior progression-free survival and improved PFS2 versus nivolumab. And that was across all lines of therapy. Like most of the patients, over 50% were in the first-line setting, but it also included second and third line. And they didn't have any new safety signals, but we do know ipi-nivo is more toxic than single agent nivolumab. And so this establishes ipi-nivo as a standard of care option. And I will stop there. See what Annie has to say.
well, I'm thinking of the people who aren't MSI and might not be familiar with all the research. So what people might not realize is that 4% of stage 4 have microsatellite instability, and first line Keytruda pembrolizumab was approved. That's about 45% cure rate, whereas ipi-nivo in the second line had about a 55% cure rate. So I actually was really surprised that moving it to the first line was so much better, and then the side effects actually compared to other research are actually a little less. So I would say the takeaway for people who aren't MSI is that earlier intervention might actually make a bigger difference. So that's what I'm reading. And then the other part is that all these side effects are being looked at really carefully. And so if somebody is more frail or just isn't up to ipi-nivo, people still have the ability, or oncologists still have the ability to prescribe nivo. And a lot of the discussion is also about, like, doing scores to figure out how well a person can handle things. And then I just want to say, if you're on immunotherapy, please don't take the advice of people on chemotherapy about side effects. Take
Oh,
the
yeah.
advice of your oncologist who says, tell me right away if anything happens, because a lot of these side effects, like pneumonitis, steroids will be given right away, and there can actually be an opportunity to re-challenge if you tell right away. So sometimes people can feel like, oh, well, if I tell, then they'll take me off the treatment. It's like, no, there's years of experience of, like, how to deal with adverse side effects, and, like, early intervention for immunotherapy side effects is a big deal. And so it could be sort of scary to see all the side effects, but part of it is, you know, don't wait to the appointment. It's okay to say, I have this cough, what happened? Or, and some patients are really incredibly proactive and get, I'm going to mispronounce this, like endocrinal panels to find out if they have any adrenal insufficiency or thyroid issues, and, like, really keeping on top of it as things go along. So, but
Um,
I think the takeaway for people who are MSS who go, why are we talking about this? Is that early intervention, as in the atomic trial, can make a world of difference. And there's, and for MSS patients, there are trials using an immunotherapy that are going into the first line. So, but we have to go sort of for the with the patients where it's more likely to get response. And we're learning a lot from the patients who are getting responses, I think.
yeah, absolutely. These are great points. I think the point about the toxicities is it's so important because immunotherapy, it could affect a person from head to toe. And so we do ask patients, please let us know anything that's happening because it could be related to the treatment. And especially important to mention if somebody ends up going to emergency department for, diarrhea, that, like, I'm on immunotherapy. And I remember in the early days, people would even be given a little card
Yes.
show. I think now, like, physicians are more familiar, but still, and there's some immunotherapies that are even more likely to cause diarrhea than this combination. And it actually, treatment with IV infliximab early on, like, reverses it quickly instead of weeks of steroids, and allows patients to potentially be re-challenged if they recover quickly. So it's a very good point you made, like, because the faster we recognize it and can treat the toxicity, then if there's a good recovery, then a person could even be potentially retreated again. And treatment of these toxicities has not been found to be associated with reduced efficacy overall. And actually, I didn't include the slide because so many slides to cover, but they did look at people who had grade 3 and 4 toxicities. They actually had, like, a little bit higher response rate. I mean, I don't know that it was statistically significant, but they would have been treated for their toxicities and there was no sign of any adverse outcomes.
Their immune system is wide awake. So, and if it's wide awake, it also can, that's why other things can happen. And I think can also, like, if somebody is pre-diabetic, you have to watch out that diabetes doesn't, happen, but your whole system definitely is affected. There's an amazing UCSF mini medical school with Dr. Max Krummel, who was part of Jim Allison's
Mhm.
lab that discovered CTLA4. And he talks about the entire body, that you have to look at as a whole system. So maybe I'll post that
I
9
think,
years later.
yeah, you just reminded me with the CTLA4, that is what the ipilimumab is. And I should have said, like, it's really thought that it primes T cells to be responsive to immunotherapy. So it makes sense to give it upfront. And uh, in this study, I also didn't mention that they only gave like 4 doses of ipilimumab. There's only 4 doses. And then it was nivolumab ongoing. And, maybe you don't even need 4 doses. Maybe even 2 doses would be enough, but we don't have that data parsed out. But just to give this in the beginning to rev up that immune reaction and then keep going with the single agent. afterwards. And all of these studies typically treat patients for 2 years. That's because the first study of pembrolizumab that was done at Johns Hopkins, they treated for 2 years and stopped. So it's kind of the convention, but there's a lot of interest in looking at what about somebody who has a complete response, or the circulating tumor DNA becomes negative and the PET scan's negative. Could we stop earlier? These
Well,
questions are under study.
and then I'm just going to say, sort of going back to the atomic, Dr. Frank Sinekrup of Mayo Clinic was saying ctDNA is incredibly important in predictive, I guess, for MSI patients. So it can also be useful in finding out maybe if there's pseudo progression and track, and like, so they're going to do an analysis because they have serial blood draws of like what happened over time, and in the same way for, the more we learn from MSI patients who are succeeding on immunotherapy, the more we can have this available. And I think Bespoke IO was specifically for people who are on immunotherapy. And so the data
Yeah,
is collecting behind the scenes.
yeah.
And then nerds like us are paying attention.
Good point. Are
Okay.
there any chat questions, Carly?
In the interest of time, I'm going to hold the Q&A questions for now until the end, so we can go ahead and go to the next study, and I'll read those at the end.
Okay.
Thanks.
So then now switching gears to patients with MSS or proficient mismatch repair colorectal cancer. This is an update of the Breakwater trial. This is looking at first-line therapy for patients with BRAF V600E mutant cancer. So looking at encorafenib and cetuximab versus encorafenib, cetuximab plus FOLFOX or standard of care. And this was a first-line study. And this was based on the study from Scott Kopetz and colleagues looking at the BRAF inhibitor encorafenib combined with the EGFR antibody cetuximab as second-line therapy versus irinotecan-based second-line therapy, and showed improved progression-free survival and overall survival compared to that second-line chemo. And so then the natural move was to see, well, what if we move it up to first line? Would it be even better? So this study was looking at that targeted regimen alone or with FOLFOX versus standard of care. And this is the progression-free survival by blinded independent central review. So people who are looking at the radiology scans without knowing anything about which arm the patients were assigned to. And we're seeing the blue curve is the encorafenib cetuximab plus FOLFOX, and gray is the standard of care. And so there is a difference here in the median progression-free survival, 12.8 months versus 7.1 months. And the overall curves, the hazard ratio was quite profound at 0.53, so almost a 50% reduction in the risk of the cancer growing or death with throwing everything at it, the targeted therapy plus chemotherapy. And then this was the update we got at ASCO, which we hadn't seen previously at GI ASCO, the overall survival now mature. And this was really astonishing because the median overall survival was 30.3 months with the targeted therapy plus chemo versus 15.1 months with the standard of care chemo. And I should have mentioned BRAF V600E is known to typically be more aggressive type of colon cancer, not always, but generally so. And so this median overall survival of 15 months on the standard of care is in keeping with what we have seen in other studies, as opposed to on the big US trial C80405, the median survival was 30 months among all comers, but it was around 17 months with patients with the BRAF V600E mutation. So here we're seeing with this targeted therapy added to the chemo, wow, patients are having survival, on the order as if they didn't have this BRAF V600E mutation. So this is really quite a breakthrough. And then they looked at the overall survival between all three arms, and you can see here the targeted regimen is not bad. It's still appears better than the standard of care chemo. So I think if somebody is not able to tolerate the targeted plus chemo regimen, they could be offered the targeted therapy, and that would be better than the standard chemotherapy. Which the standard of care was chemotherapy. I believe bevacizumab could be part of that as well, Avastin. And overall response rates, quite good, almost 66% with targeted therapy plus chemo, 45% with the targeted therapy alone, and 37% with standard of care. Um, and of course, we're going to expect more toxicities. I was worried about that, because EC itself does have some toxicities. And what we're looking at here, the grade 1, 2, the mild, moderate toxicities are in the darker shades. This is with EC plus FOLFOX, and this is standard of care. And the lighter areas are the severe toxicities, grade 3 and 4. And so there is more toxicity for sure with this regimen, like when you see things like anemia and neutrophil count decrease, that could also be because patients stayed on this treatment longer than when they just got the chemo by itself, because we don't really expect EC to cause anemia and neutropenia, but that's reflecting that they were on treatment longer. But there's more, vomiting, decreased appetite, rash for sure, 29% versus 4%. The EC regimen by itself actually has a very low rate of severe toxicity. So the key points were that this breakwater trial showed that by adding encorafenib cetuximab to first-line FOLFOX, there's a significant improvement in progression-free survival versus standard chemotherapy and response rate. And now we saw also overall survival. And this was considered generally tolerable. And so this has become a new standard of care for patients with BRAF V600E mutant colorectal cancer. This study is continuing with an arm with FOLFIRI as well. So stay tuned for that.
Well, it's wonderful to see progress with BRAF. I consider it the most aggressive mutation in colorectal cancer. And, I remember once seeing an ASCO GI where Mayo and MD Anderson said the average overall survival is 22.5 months. So to see a first line approach getting to 30 months is a big deal. And I think that there's a lot of people who don't even make it to the second line with the current standard of care of
Right.
using chemotherapy. And BRAF tends to go older. So it tends to have, like women in their 70s who are smokers, who still are important, even if you smoke. But, so like finding ways to help everybody. I consider BRAF as sort of, it can be a very traumatic diagnosis where there's a lot going on, there's a lot of problems going on. So, having 30 months, the side effect profile isn't easy, but 30 months where you can actually have life and create memories versus, if people are living less than a year, that's pretty hard to do. And I think part of what has to also happen is that we need each of these trials to report out by peritoneal mets. And I
Mhm.
like that they talked about whether there's liver mets or not, but
Good. Yeah.
20% of BRAF have peritoneal mets compared to like 12% of stage 4. And like the Anchor CRC trial, which was first line, which was just the Beacon doublet, they had like
Mhm.
37% of people had peritoneal mets. So you
Okay,
you
that's
really
quite
need
a
to
lot.
sort of figure that out. But I love that you said that EC, the Beacon doublet is an option, because I think what people don't always understand is that once it gets approval, FDA approval, then oncologists have more leeway in using their medical judgment and figuring out what is best for their patient, or trying something and going, okay, we need to take one of these off. So there's still
Yeah,
worry about what's next to do, but it's real so important that everybody get a shot at making it to second line, or to
exactly.
have a first line that lasts a long time.
A great point. And we didn't show it, but all the subgroups showed benefit with the EC with FOLFOX, including those patients with liver mets or 3 or more sites of metastases. So,
And then I just also want to say this was funded by Project Frontrunner. I think that's an FDA thing. Having first line trials for stage 4 patients is so important. And also just shout out to Australia. This trial opened during the COVID shutdown. And I think think it was the Australian patients who were like making the safety lead and fill up. So thank you, Dr. Desai.
Yeah, kudos. Amazing studies. Shall we move on? Okay.
Yeah.
So now we're going to talk about some immunotherapy for patients with metastatic MSS or proficient mismatch repair colon cancer. And so look at 3 trials quickly. This was a very interesting study presented by Dr. Anwar Saeed from University of Pittsburgh, looking at a new molecule, DSP-107, first-in-class bispecific 4-1BB T-cell engager with and without atezolizumab. And so this, this was a new molecule for me. This is actually not an antibody, but it's a fusion of 2 different proteins. So this part, the SERP alpha side of this molecule binds to CD47, which is overexpressed on cancer cells, especially in liver metastases cells from colorectal cancer, particularly increased after chemotherapy. So this part of the molecule anchors the drug to the cancer cells. And then this part, the 4-1BB ligands, bind to cytotoxic T cells, so T cells that are out to kill foreign cells. So it's bringing those T cells to the tumor. And the study patients who had had 2 previous lines of chemotherapy. They did not have any prior Stivarga, regorafenib, or TAS-102, and randomly assigned them to this monotherapy with this DSP-107 or the DSP-107 plus atezolizumab, which is immunotherapy. It's anti-PD-L1 antibody. And looking at overall response rate, progression-free survival, and overall survival. And in this study, 78% of patients did have liver metastases, which is important because there have been some studies that we'll look at some that have activity in patients with MSS colorectal cancer as long as they don't have active liver metastases. But most of our patients do have liver metastases, so we desperately need drugs that will work for them. So this study included a lot of patients with liver metastases. So here we have the toxicities, looking at, sorry, how was this arranged? I'm sorry. These are all the treatment-related toxicities by grade, and most commonly was infusion reactions, 42%, and fatigue, nausea, anemia. There were very few grade 3, 4 toxicity, which is in the column all the way to the right, which is nice to see that this drug doesn't have a high rate of severe toxicities. Here we are looking at the efficacy in terms of response. And so with the monotherapy, they didn't have responses so much. They had 21% disease control rate, so like prolonged stable disease. So it was basically 4 out of 19 patients had stable disease. But with DSP-107 and atezolizumab, the combination 21 that's shown here had, in the waterfall plot, had a deep, durable, objective response. Like it lasted more than 18 months. You can also see that in the swimmer plot. And one was a complete response and one was a partial response. So this is like very interesting. And there's a 62% disease control rate with, again, the doublet DSP-107 and atezolizumab, and 73% of these patients had liver metastases. So I didn't mean to say like there were a lot of patients. It is a small study, but most of them had liver metastases. And so seeing, 60% control rate and 10% having like significant response is certainly encouraging. And this is moving on to a larger study. Sorry, I forgot I had this slide with the overall survival. Again, this is a very small study, but these curves are quite interesting because DSP-107 plus atezolizumab is this bluish purple curve and the monotherapy is in green. And this is out to like, this is 15 months here. Again, small numbers, but clearly appears to be a separation of these curves. And when you look at The median overall survival was 17 months with this combination, 8 months with the monotherapy. And this is in the third line setting. And to put it in perspective, what do we get with third line chemotherapy like TAS-102, which is Lonsurf, or fruquintinib or regorafenib? You're getting around like 7 months. TAS-102 with bevacizumab, 10.8 months. Most of those patients in that study had not had prior bevacizumab. So this certainly looks worthy of further study. And so I'm excited they are moving on to another trial.
I was thrilled when you chose this abstract. The first time I saw DSP 107, I looked it up on Twitter, which is my library, and there was a photo of a poster with Dr. Jason Luke out at
Mm.
UPMC, and he's a big name in immunotherapy in melanoma. And I'm going, okay, well, maybe this is something. And it was great to see Dr. Seed report out at ESMO 24. And, it's so important to have any kind of hope with liver mets, and to have something that actually is expressed on liver mets be a, I'm not sure if you would call it a target, but it seems like a target. And
Mhm.
it's very exciting. The next trial is, she said it was the first quarter of 2026. So, anyway, it's exciting to see this. I hope all these things hold out. They're also trying to look at the expression of the exceptional responders to see like if
Mhm.
there's biomarkers that can help. And it might be
Yeah.
sort of hard for people to understand the plot, but like those were really long,
Yes.
but there's also between the two aqua lines, all those people basically either had less than 30% progression, uh, or around 30% regression. Um,
Yes.
so that's why it's sort of stability. It's up. It's the first couple of patients where it's like, okay, did not work. So trying to figure out who those patients are so that people get the maximum benefit. And then she was talking of adding. Dr. C was talking about adding in an arm with. I'm not sure if it was. I think it was with long surf. So
Okay. Yeah, they'll probably have to have a standard of care arm at some point.
yeah.
Um, but yeah, the swimmer's plot, the x-axis this is in weeks, and so like, these two patients who had a response, it was well beyond 1 year of duration. So definitely very interesting to try to figure out why did they have such a good response? How can we translate that to everyone else? Um,
Or not waste people time if they don't have the right biomarker. It's like, okay,
exactly,
on to
right.
something else.
Exactly. And so just a couple more of these studies, because again, this is such a huge need for our patients with metastatic MSS, colorectal cancer, to get immunotherapy to work for them. And so this is a poster that was presented by Dr. Danang Lee from City of Hope. This is safety and efficacy of ADG126, which is an anti-CTLA-4 masking antibody. So it's kind of like an ipilimumab, but different, in combination with pembrolizumab, the anti-PD-1 antibody. And so this this antibody is thought to be activated in the tumor microenvironments in that low pH environment, so it could possibly be safer than another CTLA-4. This study had 67 patients, about a third of them had 3 or more lines of therapy. This study did not enroll patients with liver metastases. And they were looking at different doses, like 10 mg per kg every 6 weeks, or every 3 weeks, or 20 milligram loading dose, then 10 or 20 ongoing. They did find, of course, increased toxicity with the higher dose. Um, and here we're looking at a summary of the treatment-related adverse events. I mean, really nothing surprising, kind of what we would expect with a CTLA-4 and PD-1. So hypothyroidism, diarrhea, pruritus, adrenal insufficiency. Here we're looking at the efficacy. This is very interesting. So we got the spider plot. I don't know if this shows up too well, but the dark red is the 20 milligram loading dose followed by 10 mg per kg every 3 weeks. And the purple is the 20 milligrams every 6 weeks. And here we have the two 10 milligram doses. And so you can kind of see there are more lines going down with the higher doses, more lines going up with the lower dose. So they are interested in this loading dose of 20 followed by 10 mg per kg every 3 weeks. And in terms of response rate, that's shown down below. 17% with 10 mg per kg, 29% with 20 mg per kg. And then they had an overall survival plot here, bottom right, patients treated at 10 mg per kg. They combine them every 3 weeks and every 6 weeks plus pembrolizumab, and then compared to historical control of like fruquintinib. So 19.4 months median survival, so kind of similar to Dr. Saeed's study. So this is also very interesting data. This company is going to be launching another randomized trial. I believe they're going to be looking at 2 different doses, and maybe we'll have a standard of care arm as well.
Again, another abstract I'm glad you chose. I happened across this trial because there's a presentation with Dr. Faki talking about immunotherapy and immunotherapy and liver mets and lung mets and the differences. And then in the end, he added in this trial, and I was like, oh wow, this is. I know there's a lot of people who are interested in with lung mets who are interested in immunotherapy now because he's really sort of brought awareness that there's a little more response if people have lung mets. There's a better chance. So it's
Yes.
nice to see this. I did listen to some of the company webinars, and it sounds like they're really trying to figure out the side effects and how to avoid side effects. I think in the coming years we're going to need to have comparisons of all these trials in terms of side effects and the number of
Right.
people in the trials. What's interesting about this is that they're going to be opening a trial in Singapore for early stage patients, sort of as a preventative thing, like I think it's in minimal residual disease.
Oh, nice. Yeah, I didn't know
Yeah,
that.
so I'm glad that the company is moving forward. It's always so unpredictable what the funding is going to be
Yeah,
on
I
everything.
know.
So um, I
Yeah,
think, and
sorry, this is,
that's part of what ASCO is about, is like for people to get funding on promising trials. So uh, and I good luck on this, and I hope it opens the next phase opens through. I mean, technically, I think this one is open, but I think there's a very long wait list, is what I had heard.
yeah, there's such a huge need for these studies. And so it's good to see so many. And of course, we already had heard about botensilimab, balstilimab, showing activity, about 20% response rate in patients without liver metastases. So it's good to see other molecules having the same activity. It's, so just this is a real effect. And then the last one in this vein is from Dr. Faki. That was a good segue. This is a vilastobart, or XTX101. This is also a tumor-activated anti-CTLA-4 antibody. So like ipilimumab, would prime the T cells to get ready for the response. And so here we see, like, they were showing the data for colorectal cohort, MSS colorectal cancer, with and without liver metastases they had studied, and 44 patients, 17 with liver metastases. And they were showing here the swimmer's plot of treatment duration. This is in weeks, with this anti-CTLA-4 with atezolizumab. The dark lines are the patients without liver metastases. So you see like the duration on study is longer, but the light gray lines are those with liver metastases. So some of them did have some prolonged benefit, but then what they reported at ASCO was results in patients without liver metastases. And what they're showing is that this combination had a 26% response rate. So you can see here below that 30% cutoff, that's how we define response on these trials. A good number with stable disease, and then about there are some here, I don't know the exact number, who had disease progression. And then looking at weeks from first dose in the spider plot, can see they're out to 36 weeks here. So we don't have like very long-term follow-up, but it does look like these are sustained responses. And in terms of toxicity, it's hard to say that this is any safer than anything else. 7% of patients had colitis, 25% required steroids or other immunosuppression. But it's, again, just great to have more agents active in this area, and potentially safer than what we already have.
Uh, I'm glad again that you chose this. Super interesting. The first time I heard about it was a physician quietly mentioned it. I'm like going, what? Okay, I'll pay attention now. We do have like only 10 minutes left. So
Yeah.
if you wanted to talk about the challenge trial.
Challenge, yeah, we should, yeah, we should get going because this is such an interesting study. So kudos to the colleagues in Canada who conducted this trial, looking at adjuvant exercise as a treatment for patients with high-risk stage 2 or stage 3 colon cancer. The study was long awaited, took a long time to enroll, and presented its results at ASCO. Enrolled patients with stage 3, so lymph node positive, or high-risk stage 2 colon cancer who had completed their adjuvant therapy within 2 to 6 months prior to enrollment. They had baseline fitness testing, and if they were at a certain level, like they would not be eligible. I think it was 15 MET hours per week of exercise at baseline, not eligible. But below that, then they were randomized to structured exercise program and educational materials versus just educational materials. And so what they were trying to do was to increase physical activity by 10 MET hours above baseline. And they defined a MET as the amount of energy we expend just sitting for 1 hour. And so apparently with 1 hour of brisk walking, that is 4 MET hours. So they were trying to get just 10 increased MET hours, which could be like walking briskly 45 to 60 minutes, 3 to 4 times a week, or something equivalent to that. And in the prescribed exercise, it wasn't just working out. There were sessions, like 12 mandatory sessions the first 6 months, every 2 weeks in person with a trainer. And then there were other strongly recommended sessions. And then 6 to 12 months, it became a little less intense. And then 12 to 36 months, again, they still had mandatory sessions, but monthly. So this is really like a behavior change intervention, not just recommending exercise, because that was the control arm. They enrolled 889 patients, mostly Canada and Australia. Um, about 60% had FOLFOX or CAPOX, the rest capecitabine, 8% other. The baseline characteristics were balanced between the arms, and the adherence to these mandatory sessions, 83% in the first 6 months, and then down to 63% after the first year. Toxicities of exercise, musculoskeletal adverse events, 19% versus 12%, that is to be expected. And this was a disease-free survival, 80.3%. This is at 5 years in the exercise arm versus 73.9% in the health education arm. And so they said, like, for every 16 people, exercise prevented one person from having recurrent or new cancer. And then this is a look at like what were the recurrences. And so what really was impressive is that in the structured exercise program, 16 patients out of 445 had liver metastases compared to 29 patients out of 444 in the educational arm. But there was really no difference in lung metastases or other sites. So that was quite interesting. It really was impacting liver. And then in terms of new primaries, the exercise arm had far less breast cancer, 2 versus 12, and prostate cancer, 5 versus 9, and colorectal cancer, no second colorectal cancer primaries compared to 5 in the education arm. And so overall survival, this is like at 96 months, 90.3% in the exercise arm, 83.2% in the health education materials arm. So exercise is presenting 1 out of every 14 people from dying. And they put this into context of like, what do we get with our treatments to try to improve survival, our drug treatment? So with the addition of oxaliplatin with all its neuropathy, adding that to 5-FU, we got an increase of 5% overall survival at 10 years compared to 7% at 8 years for exercise. And similar results with these treatments for lung and breast cancer. So, this was a really remarkable data showing the structured exercise program improved. They showed improved fitness, patient-reported outcomes, but disease-free survival, overall survival, on the order of magnitude comparable to what we see with oxaliplatin. So we should be considering this structured exercise as a treatment. And it's not just knowledge about exercise, it was actually that program that really resulted in this change. So the challenge is on all of us in oncology, like how can we implement this for our patients? And, this is just an example of a, government funded academic cooperative group trial that answered a question that, pharmaceutical companies would not be able to take on. So kudos to the investigators.
And definitely a lot of people are very excited about this. My roommate and I, we were sort of like, we're not as sure, but I can't argue with the evidence. Although Timothy Olivet did, and that he talked about, who actually left the program, why did they leave? I think that it makes sense to me that there's people who are probably really frail who weren't asked to participate in this study. Um, However, I think that the idea of a structured program makes a lot of sense. I think we just have to remember that the first 3 months after colon surgery, you shouldn't be pushing yourself. Like people need medical okay to even do yoga, let alone. But the idea of a structured class is so important. Like survivorship, the people are supposed to have a survivorship plan.
Yes.
And so if you don't have a survivorship plan, one, complain. Two, there are some downloadable ones, but in the survivorship plan, 150 minutes of moderate exercise a week is recommended. And I think if you get to this goal in like at the end of 1 year where you're actually adding 10 met hours, which could be up to 4 hours a week of exercise, 2.5 to 4 hours a week of like brisk walking, um, that would be great. But I think you have to like give yourself time. And I think also if you're deconditioned, it's important to like have somebody who's like making sure you're knowing how to stretch out and how to not have any injuries happen. A
Hmm.
lot of NCI centers and probably even Cleveland Clinic have amazing programs with integrative health, but also like, there's Live Strong has programs at the Y where people can actually get help with people who understand cancer patients, and that there's going to be a time lag between getting back to your full self. And, you know, there are so many resources out there. Please like take advantage. There's online resources that are free. And I think accountability is important, and having, somebody who's just really wise to understand the needs of your body is super important. And you'll sleep better.
Yeah, no, it's all great points. There was like I think 8 patients more dropped out of the exercise arm than the control arm. So could it be because like it was too difficult? And so even though this is a large randomized trial, it raises that concern. Is it truly randomized, or is there some imbalance? But I think, taking this into consideration, like, the minimal downside and these remarkable results, we definitely want to implement this, but have to figure out, we're going to be talking with physical therapy here, and we do have integrated medicine, like how best to do this. I think there'll be a lot of studies coming out looking at, is there a way to do this in a less intensive way, like maybe with like remote exercise trainer, like using an app, so that like wherever you live, you can still, get the benefit
And
of.
then I'm going to go back to ASCO 2017. They had two programs for strenuous exercise for stage 4 patients,
Mm.
and they didn't show that it really was helpful. So if you're stage 4, please give yourself grace,
Yeah.
especially during chemo week, and just understand moderate exercise might be enough. And sometimes rest is part of healing. So we are at the hour. So Carly, what do we do now?
Sure. If you guys have time, we'll leave on one question, and that is, what is like the one key takeaway that you would take from ASCO 2025, whether that be from the science or your experience or the networking? What is like the one thing that you would leave everyone with? We can start with Dr. Krishnamurthy.
Yeah, that's tough. I have to say, I felt like this ASCO was like one of the best ever. And I think maybe because of these number of like exciting studies that reported out for patients with colorectal cancer, but also like just like the community, like bringing everyone together. It's so uplifting to see like, like we're not just in our little silos. We are all like this giant community, like trying to end cancer. So I just found that so rejuvenating.
Annie?
Um, I think Dr. Bianchi, he was talking about a lot of this is about precision medicine, and that there's times that we can use that, and to be able to show results in earlier stages and is a big deal. To anything that shows results with peritoneal mets or liver mets is just so important. As Dr. Krishnamurthi says, it's like 55%, 60% of stage 4 patients have liver mets. So but we need to find stuff for all, and the things that we find in BRAF help KRAS, and the
Mhm.
things we find in MSI can help MSS, hopefully. Let's find biomarkers of response.
That's great. Thank you guys so much. In the interest of time, we'll end here because we are at noon Eastern. But thank you both so much for your time. Thank you to the audience for sticking along with us for the full hour. I will send the recap recording to your emails in about a week, give or take, so that way you can rewatch and feel free to respond back with any questions you might have, and hopefully I can get those answered for you. But thank you, everyone.